So first of all, thanks for inviting me to this outstanding Congress. I think we hear a lot of outstanding lectures on special aspects of interventional cardiology. My part is to talk with you about guiding complex PCI with HD-IVUS. And my first disclosure is that I'm a strong believer in intravascular imaging. In my hospital, more than 90% of the interventions are performed under the guidance of IVUS. So you will not hear from me where you don't need it or where you cannot use it. You will hear from me that I will try to convince you that it is extremely helpful in daily clinical routine. I think you all know about the guidelines, which gave a class 1A recommendation on to use intravascular imaging. It's not only IVUS, but intravascular imaging in general to guide complex coronary interventions. And the definition of complex interventions is based on, and I want to discuss this with you, why the guidelines are somehow restricting the recommendations to complex situations. And the reason is maybe due to the fact, despite we have intravascular imaging more than 20 years now, we have high definition intravascular imaging, I would say, widely available since the year 2020. And this is when the wasted amount of evidence started to develop in, of course, selected patient population. And if you look what happened afterwards is that we saw, if we expand the indications, we treat more patients, that we really can have an impact on patient outcomes in all-cause mortality. And this is, of course, due to the fact that we reduce the amount of target region failure significantly if we perform intervention with cardiovascular imaging. And one of the main reasons for this is, I think you all know that we have significant drawbacks with coronary angiograms alone. You see the amount of a stenosis maybe, yes, within coronary angiogram, the fluoroscopy, but you cannot really appreciate the amount of disease, which means how much atherosclerosis, what the amount of calcium in the whole vessel. So you see only one aspect of the disease. And what we see within fluoroscopical image is a two-dimensional aspect of the disease, of the stenosis. But if you perform intravascular imaging, you have a rotational image, which means that you see the three-dimensional you have a three-dimensional information about the aspect of the disease. And what you will see, and this is what I experienced when I started my experience with intravascular imaging, that it really has an impact on what you do in daily clinical routine. Because if you don't see it, you will not treat it. But if you see if you see specific anatomical findings, it will change your treatment plan. This has been published that in more than 70% of patients, you will adapt your interventional strategy when you use intravascular imaging. And this is true even in non-complex clinical scenarios. And I can tell you that it's really, you will really see it if you use it in daily clinical routine. I personally use the Assist HD-IVUS system because it was the first system available on the market, and second, because I really like the Kodama catheter, which has a high crossing capabilities through tight lesions. I had never experienced any problems with that the catheter was trapped within a tight lesion and so on. So I really rely on this catheter, and you have different imaging capabilities on how you want to see the vessel, the lesion, if you're focusing more on the lumen, if you're focusing more to identify the plaque, or you can have a mix of both if you use the classic view, which is the standard view in most of my cases. And just to compare the HD-IVUS, the 60 megahertz systems with a 20 megahertz system, I think it's not fair to compare this. I think it's true that if we look on those images, it's really hard to interpret and to make fair clinical decisions out of them. But this is the next step. This is today's clinical routine, and those images are very good to help you to guide your daily clinical decisions. And this is what we have to compare. This is what we have today available, and this is what we should use in our cath labs today. Of course, there's another competitor, which is not IVUS, it's OCT. and we have to think about what is better. And sometimes you have restrictions that you can have only one system available in your cath lab, and you have to decide what is the workhorse device in your clinical routine and what is nice to have. And from my point of view, I see some relevant advantages, especially with HD-IVUS, because you have a more anatomical imaging of the vessel walls. You see the adventitia, the intima, so you see a more realistic image of the vessels. Of course, you need no amount of contrast when you use IVUS. You can use it like you use a transthoracic echocardiogram. You can do multiple run. You can go back and forth. You can go to the lesion of interest, to the region of interest, and see what's going on there. Though it's really practical in clinical routine. And if you look into clinical data comparing OCT with HD-IVUS, there's no difference in outcomes. So I personally don't see big advantages of OCT. It's the other way around. There was this publication from this year comparing the accuracy of IVUS with OCT in silicon models. And what the company found out was very interesting, because they saw that the IVUS, if you measure the diameters, has a higher accuracy measuring the right diameters as compared with OCT, without losing precision concerning the resolution to identify even smaller pathologies like dissection and so on. So there's no real drawback of IVUS. Maybe there are some advantages of using HD-IVUS as compared to OCT. But how should we use intravascular imaging in daily clinical routine? I think it's a step-by-step approach that you should establish in your workup. And there are 3 steps that you should use. The first is pre-procedural imaging. It's very important to assess the lesion complexity. The raw model is calcification. The plaque morphology, it's important to plan how long your stent should be placed. Then after you had maybe lesion preparation, of course, it's important to see if you were successful, if the calcium is cracked, for example, if you perform orbital atherectomy and so on, and then plan your stent. And of course, and this is even as important as the first 2 aspects, and I see that sometimes it's not being done, is that you perform a post-PCI imaging to make sure that the stent is properly opposed to the wall, that there's the minimal stent lumen area is okay, and then you have no edge dissection. And of course, it's important that if you start imaging, that you know what you have to expect. So you have to gain experience with the images. One aspect is a technical aspect, just to perform your measurements accurately, which is really simple. You just draw a line and you make your measurement, and then you will see what the dimensions are, and you can believe it, what you measure. And the second aspect is the anatomical aspect, that you can interpret the images well. This is what we have to learn when we do transthoracic echoes. Then we have to learn how does look hypertrophic cardiomyopathy like, and so on. The same is true, of course, if you perform intravascular imaging, but it's no rocket science, and there are only something that you have to think about. This is a normal, I would say, benign plaque. There are more situations which increasing the risk, which is a fatty plaque where I have this hypodense echogenity within this plaque, and we have those hyper-attenuated plaques. You see it here, the hypodense part of this plaque, which means that the necrotic core increasing the risk of plaque rupture if you place a stent within this plaque. It does not mean, even there was one publication on if it makes sense prognostically to seal these plaques, but it does not mean that we have to treat those plaques as a lesion. But if you have a distal or proximal lesion and you plan your stenting, the stent edges should not end in such a fragile, unstable plaque. So you must cover this plaque with your stent, and it's important to know this and to plan and adapt your strategy. And HD-IVUS in this context, impact on outcome, you have very good capabilities to identify those unstable plaques, which is much better if you use HD-IVUS than non-HD-IVUS. what I have already said, the raw model for pre-procedural imaging and technical strategy planning is calcium, because we have different tools available how to treat calcium. It's lithotripsy, it's orbital atherectomy, it's a rotational atherectomy, and we have guidelines already based on experience, based on evidence, which give us a good, I would say, a good treatment plan. What to look for? It's the amount of calcium, the arc of calcium, if it's 360 degree, 270 degree, if there's a calcified nodule, and it's the length of the calcium that we see. And depending on what we see, we can already anticipate that there's need for calcium preparation, and depending on the specific anatomy, we already have experience what preparation technique might be the optimum strategy in this case. Of course, you can always plan your cases differently, but I think it's very helpful to have such a treatment plan already available, which is based on high expert, not only opinion, but experience. And this is one case I just wanted to show you where intravascular imaging was extremely helpful. First, to identify the culprit lesion, and second, to plan treatment. We plan our treatment. A patient with ongoing ischemia, 84 years old, coming to our emergency department. You see this RCA, and there's this kind of lesion. And of course, you can start now to do multiple angulations to somehow assess the severity of disease. And this is one point where I really can say, if you stop, then do not do multiple angulation, but start with intravascular imaging. This will really help you to speed up your process, or at least it will not prolong your intervention, because this is the one image, maybe a second one, and then you go in, because you know that this is a culprit lesion. Of course, we assess the LAD and so on. And then you do your intravascular imaging, and you see this image where you see a lot of circumferential calcium. You see a calcified nodule here, an eccentric calcification, and then you can do your measurements, and you see how tight this lesion is as compared to the cross-sectional area, the reference lumen area. And of course, this is a significant severe stenosis, which we treated with orbital atherectomy. I like orbital atherectomy in such cases because you can go back and forth. So you can do several runs with the same tool and somehow try to treat the calcium, especially if it's eccentric in a large diameter. And then we do a post-dilatation, and then the patient was treated with a good result. What we have to think about, this is a post-procedural access. So I talked about pre-assessment, look for the amount of, or the composition of your plaques, look for calcium, how to plan your treatment. And of course, we have to think about the post-treatment results. And two things which we have to talk, what we have to check is the position of the stents and the stent expansion. This is very important because the instant restenosis is still the Achilles heel of interventional cardiology. And once again, we have very good guidance from our from the EuroPCR or from the American societies, what to look for, what is an acceptable result, and what should not be left behind. And this is not arbitrary. This is because of the evidence where we saw with intravascular imaging, with the results from the study. If a patient leaves a table with this result, then the likelihood of target lesion failure is relevantly diseased. And here the raw model is instant restenosis. It's still the most common cause for stent failure. It accounts for 5 to 10% of all coronary interventions. And even if it's treated, it has a very high recurrence risk. So this is important to avoid this, to not leave a patient with a not good implanted stent from the table, because instant restenosis increases the risk of morbidity and mortality. And the first step to treat such complex cases is to really classify what we see. And there's one, I would say more historical classification based on the angiogram. What we see, it's a pattern of instant restenosis, what we see when we do perform our angiogram. And the second step is not only to describe it, but to really understand it. And this has been published in Neurointervention 2020. And of course, this is based on intravascular imaging, because depending on the underlying pathology, we have to guide or to adapt our treatment strategy. If it's an underexpanded stent, if you have a stent fracture, if it's neointimal hyperplasia, or if it's neoatherosclerosis. And there was this very helpful paper from Ron Waxman, who divided the mechanism in it's a mechanical problem of the stent or if it's a biological problem. And then he gives us some therapeutical guidance on what we should be aware of, how we must treat maybe this patient with our interventional toolbox. And this is one patient. Unfortunately, the image here is not running, but this is the IVUS run. You see maybe just without the contrast that there's a long diseased and stented area of this LAD, and the patient was referred to my hospital just to perform a lithotripsy in the proximal part. But of course, we do intravascular imaging because the guidelines give a 1A recommendation to do intravascular imaging in complex coronary disease, and every instant restenosis is a complex disease. And you see, if you look into the images and if you look into the patient, that you will have, the longer the lesions are, you will see more than only one pathology. And in this case, we have 3 different findings, which then have to be treated differently. In the distal part, we had a significant underexpansion of the previously implanted stent. In the medial part, there was a neointimal hyperplasia of the proximal of the stent, and the proximal part, there was the stent integrity was not good because there was an eccentric calcification with a significant underexpansion of the stent, which means that we have to think about different tools. The distal part I treated with a high pressure balloon and DCB. The medial part treated with a scoring balloon and a DCB, and the proximal part was treated with the intravascular lithotripsy, high pressure, and finally a drug-eluting stent within the stent to somehow recover the architecture of the vessel and the stent. So my message for you is just try it, use intravascular imaging. You will see that it's extremely helpful in your daily clinical routine, and it really will change your mind on how you think about the patients. It doesn't mean that you made something wrong until now, and now I tell you that you have to do everything right, but it's really helpful, and everyone should think about what are the measures that I can take to improve myself, and you will see it's extremely helpful to do it. And the reason is that we have good evidence, and we had good reasons to recommend intravascular imaging for PCI guidance, because we really have an impact on our outcomes. And I just would encourage everybody to try it in every clinical routine, because if you try something in an easy case, it will be much easier in complicated situations. So don't just use it in a highly calcified bifurcation situation with dissection, where you have to think about 20 different things simultaneously. Use it in easy situations, adapt your strategies, and then it will be much easier in complicated situations. And I'm pretty sure that future innovations will speed up the process and optimize workflow with artificial intelligence, lesion detection, and so on. So I think there's a lot that that will come in the future, and we will talk a lot of intravascular imaging in the ongoing congresses. Thank you very much.